We move on. Next talk will be by Dr. Unnikrishnan Nair. So he'll be talking about assessing disease progression using multimodal imaging. Dr. Nair.
Good afternoon, and thanks for the kind invitation for this talk. Uh, so multimodal imaging as a tool can be considered as many parts, but the whole idea is that the whole is greater than the sum of the parts, and how to use multimodal imaging with, I'll be talking mainly about the Heidelberg system, sequential or simultaneous imaging to create assessment of various parts of retinal diagnosis. Here we'll be looking at MMI exclusively to look at the progression analysis in these 5 conditions and see how it helps. So geographic atrophy, there are many ways to identify geographic atrophy, starting from the multicolor, better delineation than the color fundus photography and infrared, and then you have the fundus autofluorescence and the other modalities, but the favorite modalities for us are the OCT and the OCTA. So just to look at this, you have the picture on the extreme right is a regular color fundus photograph, but when you apply the multi-color, you have exact dimensions of the areas of geographic atrophy, and that is one of the greatest advantages of using different light color sources to identify geographic atrophy. Just coming quickly to autofluorescence. The autofluorescence is based on the principle of the presence of lipofuscin inside the RP, and the absence of lipofuscin is what creates these beautiful images of geographic atrophy. So you can see confluent geographic atrophy at the extreme right, and you can see patchy geographic atrophy. And when it is hyper autofluorescent, those are the RP that is going to go into geographic atrophy. It's a brilliant concept. So the progression of geographic atrophy, RMD, is shown by this very famous group of images from the original study, where you see the geographic atrophy increasing in size. And according to the same thing, there are modalities by assessing the hyper autofluorescence, so the brightness around the areas of the darkness, and categorizing into various types. And by this, there's a diffuse banded type which has a rapid progression of geographic atrophy. So I'm going to show you some other images, basically how to predict it happening. These are very interesting concepts. So you have these small hyperreflective areas over the bumps. Those are called HRF, or hyperactive foci. They're kind of the retinal pigment epithelial cells detaching from the PEDs, and that is an indication that atrophy is going to happen. Here you see one of the HRF over the PEDs, and over time you see the PED collapse, and then it results in atrophy. So that's one sign, seeing these hyperreflective foci. You see this in these cases. This is a patient which has nearly 10 years follow-up with us, and over the 10 years you can see the changes over time. The same patient increasing lipofuscinoid material changing, and over a 10-year gap it converts to this condition called C-RORA, or retinal and outer RP and outer retinal atrophy. This is a 10-year follow-up. So these are very interesting pictures which show how to predict geographic atrophy happening. You see those lines. Can I have a pointer, please? Pointer. You see these lines, vertical lines. Those are transmission lines of the OCT light going downwards, and that is an indication of imminent atrophy happening. Thank you. Imminent atrophy happening. You see these lines happening. So here, this is again, it's called a transmission tail. Where there is RP atrophy, you see this happening over here. Again, these are multiple transmission tails, and why it is important is gives this diagnosis called nascent geographic atrophy, or geographic atrophy that is about to happen. This is called nascent, where the retinal layers go down and dip over there. So again, the presence of nascent geographic atrophy is a sign that geographic atrophy is going to happen. And going one step further, you have an OCTA diagnosis. See these dark areas, that is choriocapillary dropouts. It happens before the clinical signs or the tomographic signs of geographic atrophy. So now you have OCT signs, you have OCTA signs that geographic atrophy is going to happen. And you can see these images where you have some, and a larger area where you have larger areas of dropout of the choriocapillaris. There are other very interesting risk factors, like the shape of the geographic atrophy. It's called circularity index. The more circular it is, the more likely it is to not progress. And the one which is notched and has different shape, the geographic atrophy progresses. So if you take a geographic atrophy, you make a circle and you see how much it deviates from the circle, the more deviations, called a high GACI, geometric acycloatry index, or a low one, the ones with high progress faster. That is, the more deviation from the circle, it progresses faster. Extrafoveal lesions progress faster than lesions closer to the fovea. The edge closer to the fovea progresses slower. So all these, and this is something called edge characteristics. With the OCT, you have the FAF, you have, this is called a convex hull. You can draw a hexagon around the area of geographic atrophy. The more number of sides and the more larger it is, the faster the progression. You can look at the edge, whether it is a split edge, an irregular edge, and you can assess which edge of the geographic atrophy is going to progress faster. So you have all these various indexes to find out how these are called junctional characteristics, and how the geographic atrophy is going to progress. So let's go to the next condition called pachychoroid. Pachychoroid is when the choroid is thick. Multimodal imaging allows you to image the thick choroidal vessels. You have different conditions like CSR, PPE, neovascularization, and PCV. And this is a beautiful image. Anything green on the multicolor is elevated. So you see elevated is fluid, and it shows fluid here. Multiple modalities to diagnose the same thing. This is an interesting picture. You see green here, you see a little bit of orange here, you see a kind of bumpy thing here, and this is it. You can make out a choroidal vasculature, you can make out a PED, you can make out the amount of SRF also. So this is the beauty. These imaging are depth resolved. You can see the different depths in different colors in multi-color imaging. A cross section will tell you this is a pachychoroid with a thick pachy vessel underneath it. And this is the other thing. You have different layers. Some of the layers are thin. The inner choroid is thin while the outer choroid is thick. Again, in pachychoroid, you have inner choroidal thinning, and that is made out by the OCTA as thinning. A new diagnosis is pachychoroid epithelopathy, where whenever you see a pachy vessel, a thick blood vessel, you have a bump in the choroid above it. And on further examination, I'm just flipping these slides just to show you a few important ones. On further investigation, there are 3 or 4 types of changes. Very interesting. You have a bump which increases over time, or you have a split, a bump with a split. Why is this important? Because now it is thought that these could be the precursors of neovascularization in the future. This neovascularization can go through this micro break in the RP or the retina. And this is how it progresses. You have a small bump and a bump that eventually reaches the external limiting membrane, the progression of PPE. And then you have another diagnosis exclusively now made by OCTA, that is a pachychoroid neovasculopathy. You have all these lesions, a little bit of fluid, a large pachy vessel over there. These 2 are the diagnostic features, having a bump over there and having a network on the OCTA. So multimodal imaging shows you on infrared, shows you on multicolor, shows you on OCT, and confirms with the OCTA. That's the power of the multimodal imaging. So these are again typical features. You have fluid, you have a small bump over there. The bump corresponds to a membrane on the OCTA, and that's how it is used. This is called a FIPED, or a flat irregular PED, which is flat, it's irregular, it goes up and down, and underneath it you will see vascular lesions. So again, we just go to OCTA in PCV. I'm just going to skip these things. In OCT, the new concepts about progression are that there are different types of PCV. PCV is not a common disease, and one of those things you see, the branching network underneath the choroid, as evidenced by the OCT. There are 3 types. Why is it important? This responds poorly, this responds well, this responds poorly to anti-VEGF. So the progression of treatment can be assessed by this. Going to wet AMD, multimodal imaging shows you, this is the typical things we used to do, FFA, but now we can exactly see the vascular network using OCT, a beautiful network of vessels underneath the RP, above the RP in this case. You can see it, and this is how beautiful the image looks, the OCT image of the CNVM looks like. These are other images, and why it is important progression analysis. You have different types of CNVMs based on the OCTA, of which just out of the thing, the Medusa head responds well. Things like this, like the CFAN and the fishnet pattern, do not respond. So your progression analysis is important, that it tells you which sometimes which CNVMs do not respond to anti-VEGF. And this is a good response where all these small vessels are going away. This is a poor anatomical response that after the injection the vasculature is increasing. This is a very important concept regarding progression, the presence of recurrence. It's a very important feature to look at this. The OCTA shows a network around it, small vessels around it, and the first sign of recurrence by OCTA progression analysis, you can make out whether the CNVM is coming back. These are all images in the same line. In this particular image, you see a dry part where it's inactive and an active part, beautifully seen on the OCTA. So I'm just going to skip these, so we just don't do too much over here. Okay. So finally, there are new diagnoses on finally. The new diagnosis, one is called a non-exudative CNVM. There's no signs of exudation, but you see a network on the OCTA. And why is it important to diagnose it? Because you've got to keep on watching this, because in a year, 18% of people go into having a full-fledged CNVM. So that is why these are important to diagnose. So I'm just going to skip all these, just the basic things are required. So in MACTEL, it's a condition where we actually use this a lot. You see the features of MACTEL, you see the pigmentation, you see the changes, and you see the CNVM happening. These are changes. This is what a color photo would tell you, but a multicolor would bring out everything, the pigment, the hemorrhage, everything. It comes out better in a multicolor imaging. And this is when the MACTEL has a hemorrhage inside. And then when you do the OCTA in a patient with proliferative MACTEL, you see a vascular network in the avascular zone, and that is diagnostic. This is the dynamic angiography by which we can make out as the dye goes by, you can see the vascular net coming beautifully at this point of time, and over time the leakage increases, and this is a very key important way of diagnosing MACTEL. So some of the other features of MACTEL is called invasion, where some of the vasculature goes to the lower layers and it has to be differentiated from a CNVM later. So just to summarize, in dry AMD, the fundus autofluorescence and the OCT is important to assess the edge characteristics for assessing the progression. In pachychoroid, knowing the subtypes and how will tell us how they respond to anti-VEGF. In wet AMD, identifying poor response characteristics and recurrences, identifying a non-exudative CNVM, so you catch a CNVM earlier than it has to happen. And in MACTEL also, the diagnosis of choroidal neovascular membranes are essentially with multimodal imaging. Thank you.
Thank you, Dr. Oni. That was a beautiful talk. So I just have a question for you. I think now we are having new therapies for dry macular degeneration, like Syfovre and the complement-based. So based on this upcoming exciting new therapy, where do you see the role of autofluorescence, and specifically the difference between blue and green? Because I know Heidelberg has both these features.
See, I'm not sure that, I'm really not sure that autofluorescence is going to be the key, the research tool for measuring the progression using these methods. It's a gross method, but the real methods are going to be the edge analysis, that is the ellipsoid edge analysis, the junctional features, and because knowing which edge is going to progress is going to be the most important features, and those are some of the key features. And more than autofluorescence, basically it is going to be QAF, quantitative autofluorescence, which is going to be the biggest tool in the future for dry AMD studies.
And the second thing was, if you just see a network on a octa, like you showed some beautiful, like, would you like to treat that, or would you always look for some fluid or SRF on the B scan, corresponding B scan?
So if it is a patient coming to you for the first time and you see a network and there is no fluid, you do not treat, because it's a pre-clinical, it's a non-exudative CNVM. But if it's a patient you've treated who's been quiescent for some time and you see a network, you have to treat it, because you know it's going to go to exudation soon. Thank you.
Thank you. Thank you so much.
Thank you.
We now move on. So now